activity has been planned and implemented in accordance with the essential areas and policies of the Accreditation Council for Continuing Medical Education through the joint sponsorship of the American College of Medical Genetics and the National Coalition for Health Professional Education in Genetics. ACMG is accredited by the ACCME to provide continuing medical education for physicians.
You're watching VHA TV, the award-winning satellite network of VHA.
This program is confidential. Duplication of this program without permission of VHA TV is prohibited, except for use by participating healthcare organizations.
This program is supported by an educational grant from the Robert Wood Johnson Foundation and the Josiah Macy Jr. Foundation. This program was developed and produced in collaboration with NCHPEG, the National Coalition for Health Professional Education in Genetics, RSI Focal Search, and VHA.
Hello and welcome to our program. My name is Joe McInerney. I'm the director of the National Coalition for Health Professional Education in Genetics, which is known as NCHPEG, and I'm the moderator for today's broadcast. Before I introduce the panel, we have some pre-recorded comments from a distinguished guest who will tell us about today's program topic. Dr. Francis Collins is the director of the National Human Genome Research Institute at the National Institutes of Health in Bethesda, Maryland, and he's one of the world's leading authorities in human genetics. He's also president of my board. Let's hear what Dr. Collins has to say.
Thanks, Joe. I appreciate the opportunity to be part of this important program. All primary care providers have seen articles about genetics, race, and healthcare in professional journals and in the public media. But do our traditional conceptions of racial groups have any reliable basis in biology? Does the concept of race itself have any biological basis? And what does our growing understanding of human genetics and genomics tell us about this question? And what about the use of racial categories in the clinical setting and in biomedical research? Is it warranted and helpful? Or is race such a muddled concept that its use can confuse practitioners and clinical investigators alike? The following program, which consists of several brief clinical cases, is intended to raise some of these questions and provide some guidance for clinical practice. Each taped clinical encounter between a provider and a patient and one medical student is followed by a live discussion by a panel of expert clinicians and researchers. I'll return during one of the cases to provide a little more information about biology and race. The complete sequence of the human genome, available to all researchers since April 2003, has begun to shed some light on these matters, but there is still much to learn and still much work to do to translate these new findings into information that is helpful for practitioners. We appreciate your attention, and we hope you enjoy the program.
Dr. Collins has really set the stage nicely by raising some central issues about race, genetics, and healthcare. And we have a panel with us very well suited to the task of addressing those issues. Let's meet the panelists. Dr. Gary Gibbons is director of the Cardiovascular Research Institute, and he's professor of medicine at Morehouse School of Medicine in Atlanta. He's also an attending cardiologist in the Division of Cardiology at the Morehouse School of Medicine. Dr. Gibbons directs NIH-funded research in vascular biology and in the pathogenesis of vascular diseases. Dr. Howard Levy is assistant professor in the Department of Medicine and the McKusick-Nathans Institute of Genetic Medicine at Johns Hopkins University in Baltimore. Dr. Levy also is a practicing internist, and he's board certified in both internal medicine and medical genetics. Dr. Charmaine Royal is assistant professor and director of the Gen Ethics Unit in the National Human Genome Center at Howard University in our nation's capital. She's engaged in research on the ethical, legal, societal, and psychosocial implications of human genome research for African Americans and other populations of the African diaspora. It's really a pleasure to have all of you here.
Thank you.
Thanks, Joe.
Before we begin the discussion, let me remind you that you can call our toll-free number, 800-842-2032, at any time during the broadcast. We encourage you to call with your questions and comments, and we will do our best to respond to them during the course of the broadcast. Again, the toll-free number is 800-842-2032, and the lines are now open. If you prefer, you can email your questions and comments to vhatvlive@vha.com. We look forward to hearing from you. So let's get started. We developed this program to provide you with information about the following: whether race has validity as a biological entity, the differences between biological and cultural conceptions of race, the relationship between genetics and race, in particular with respect to healthcare, and finally, the meaning and utility of race in the clinical setting and in biomedical research. To help illustrate these key messages, we have produced, as Dr. Collins mentioned, a set of vignettes with actors portraying patients, providers, and a medical student. We did not intend these portrayals to dramatize, we intended these portrayals to dramatize experiences that happen in everyday clinical practice and to raise important issues for discussion by our panel. We certainly did not intend them to be illustrations of best practices. This is a critical point that we hope you keep in mind throughout the program. The handout we've provided is a resource that you can take with you after the program. It includes some of the basic information that the panel will cover for each case, and we hope it will spare you the task of taking notes. So let's begin with case 1. This is a situation that likely will be familiar to many of you. We're going to look at metabolic syndrome, understanding risk on an individual level. This is a new patient. He presents with hypertension, obesity, he's got a glucose of 115, but an unknown cholesterol level. He's accompanied today by his wife, who will have her own appointment next week. We join them for discussion in the provider's office after history and physical. Let's take a look.
Well, Mr. Lopez, you have high blood pressure and you're overweight. At a recent health fair screening, you had high blood sugar. These are all risk factors for heart disease and stroke.
I know. I've seen all this in my family.
Right. Let's take a look at your family history. We see that a lot of your relatives have had high blood pressure, diabetes, high cholesterol, and obesity. And indeed, several of them have had heart attacks and strokes.
I've heard that Latinos are prone to this kind of problem.
Yes, we call it metabolic syndrome, and it can happen to anyone, but it's certainly more common among Latinos.
Are you saying that this is genetic and I'm going to get this too, since my family is from Mexico?
Well, you're at risk too, just based on your heritage. So all the things that we're going to talk about today will apply to you as well.
Wow. I always just assumed that I would get breast cancer, since that's what's in my family, and none of my relatives have diabetes.
Oh, that's a good point. Your specific family history is very important, and we'll have to explore that in detail when you come in next week for your visit.
So am I doomed to have a heart attack because I'm stuck with my genes, or is there something I can do?
Well, genetics is an important risk factor. We don't know to what extent genetic factors shared by Latinos versus dietary or other lifestyle habits explain the increased risk, but we should certainly work on modifying those risks.
Perhaps you noticed that the provider did not answer directly Mr. Lopez's question about whether he's doomed to have a heart attack because of his genes. Howard, what do you think of that?
Well, I think that's really where the communication issue starts. We need a yes or no answer. So to directly answer yes, I think that's an issue that the provider could have done a little better. And the point that then needs to be emphasized is no, genes are not destiny. We can use family history, we can use genetic information to identify people at greater risk for a condition. But as this vignette was subtitled, it's a matter of interpreting risk on an individual level, and then recognizing that genes are not the only aspect that goes into determining health and disease. There are genetic factors that predispose. There are environmental and cultural and behavioral factors as well, and those are absolutely all modifiable. So I applaud the provider for recognizing an ethnic predisposition, but at the same time, it's important to emphasize there's variability. There are differences that can be recognized within groups. There are things that can be done to change the outcome. And likewise, it's important not to jump to conclusions. So just being Latino doesn't mean you're going to have diabetes or other components of the metabolic syndrome. And the provider clearly needs to pay more attention to Mrs. Lopez's personal and family history at the time of her visit.
Yeah, I thought one of the elements that the provider could allude to there in developing the family history is also an opportunity to get a sense of the lifestyle and cultural aspects within that individual's family. We start with these groups, in this case Latino, to say they're increased risk, but as that example indicates, the outcome may be different in Mrs. Lopez versus Mr. Lopez. So family history gives us an opportunity not only to explore things that come in our DNA that we inherit from our parents, but also perhaps some patterns of lifestyle and behavior that we were engaged in. So we also share family recipes and family ways of doing various activities. So diet and exercise may also come out of that family history as well. There may be particular reasons why things run in that particular Latino family. So that may help bring it from a group population back down to the individual's experience.
So we want the provider to take a good genetic family history, medical family history, but also a social, cultural family history as well, as it were.
Absolutely, absolutely.
The whole thing about genetics is that, as wonderful as it is, genetic information should really complement other information that we use in treatment and diagnosis, and not using group membership as a means of determining what medication we give or what people may be at risk for.
It helps us to make predictions, but not final decisions. And it's important to recognize that we don't exclude people if they're not in a group. So metabolic syndrome is common. We see this in people around the globe as members of all different groups. So not being Latino doesn't mean you're not at risk, and certainly many groups have increased risk. And the difference between Latinos and other groups is small. It's real, but it's small, and it needs to be considered for everybody. So we're asking providers to look at all the components, take that good history, prioritize things a little bit, but consider everything.
I think the other aspect of the metabolic syndrome is really, for the clinician, it's a whole constellation of different features. And even the definition is in some area of controversy. There are different groups with different policy groups that have different definitions. And I think some of the things that are emerging is that the criteria may need to be adjusted based on ethnicity as well. So, for example, in this case, we didn't get the HDL level, but for example, in African Americans, in general, the average HDL level is higher. And so in the metabolic syndrome, it's characterized by having a low HDL. Well, what does low HDL really mean? And it could mean different things in different ethnic populations. So in that regard, understanding something like the metabolic syndrome, as you say, it's really a constellation in which we'll have to look at the genetics and the environment and the behavior, and that's really where the clinician has to integrate all that information together to deal with the risk profile of an individual patient.
We can see even within those components of metabolic syndrome, as you were saying, different factors are more common in general in different groups, right? So among blacks, there's a lot of hypertension.
That's correct.
Among Latinos, hypertension is a lesser component of metabolic syndrome, but obesity, diabetes, more prominent. The reasons for this we still don't quite know. Again, is it genetic? Is it biologic? Is it just cultural? The answer is not any one of those, right? So it's not nature versus nurture. That was never correct. It's nature and nurture, genes and environment, cultural factors and everything. Those are going to vary for lots of different reasons.
And that's one of the things I think that's hopeful for the future in terms of clinical medicine, is increasingly we're starting to identify certain genetic markers, certain genes in which those variations may play a role in the susceptibility to develop diabetes. So,
and how they interact with the environment.
And how they interact exactly with the environment, that it's not just, again, the sense that it's wired in and that you're destined, but with this sort of genetic background, these certain alleles, these certain parts of that alphabet of the DNA code, that in that context, when you do increase your body mass, you might be a little bit more prone to develop diabetes. So it's hopeful that the tools will develop with further research that will enable us to tease out who's really at highest risk of developing a lot of the complications of the metabolic syndrome. And I think that's an exciting part of where medicine's headed.
Charmaine, we seem to have some lessons here about causes of health disparities that are rooted in issues other than biology. Can you talk about that a little bit for us?
Well, there's one school of thought, and I think the earlier school of thought in terms of health disparities is that it's biological, that the reasons that we see these differences are biological. Much of the research that has been done thus far has really looked at the social and environmental issues in terms of access to care and all these kinds of things. So we're really just now bringing genetics into health disparities research. And the key is, as we said before, recognizing that it's not either genetics or environment or behavior. It's all of the above. And the key, and we really need to design studies that represent that and reflect that. And our models need to be more comprehensive as we put all these variables into the picture, because we're not going to solve the problem of health disparities by looking only at genetics, and we're not going to solve it by looking only at the social and environmental factors. It needs to be both.
Understand. Anything else we need to add to this case?
Well, I guess the only one other point relates to Charmaine's point about race and ethnicity. I think it's often as a proxy, really, for a number of other things. And so I think clinicians often make these categories based on skin color, if you will, or race, ethnicity. But in fact, there's often this proxy for socioeconomic status and educational status and other parts of the history. So I think once we start to break apart the categorization by race and ethnicity into the components, I think we're going to really enable ourselves to take better care of our patients by again, breaking out what might be biological, what might be cultural, what may be behaviors, and again, really target that as how we take care of the patient.
Yeah, I think a good point that you made, Gary. You just said biological, and we tend to talk about race and genetics, or we talk about genetics only as the biological component, but there are other biological factors that are not necessarily genetic, and it's important to remember that as well, that not everything is genetic, hereditary, inherited, but there are other biological factors.
In fact, one of the features of the metabolic syndrome, in fact, is that clearly gender is superimposed on a lot of these other things. And so, again, you have this interface. For example, African-American males are perceived to have a low prevalence of the metabolic syndrome because the obesity seems to be more predominant in the African-American female. And so there are different aspects, as you say, of the biology superimposed on genetics and again, behavioral aspects as well. So I think as the clinician addresses these things, considering all those factors is part of dealing with something as complex as the metabolic syndrome.
I think a big point to emphasize here is that we've talked about a lot of groupings and presumptions or assumptions that can be made on the group level that data supports. Yeah. But again, the individual patient may or may not manifest those particular risk factors. So we can look at an African American or an Asian and make some inferences about what the diet might contain and what the behavior patterns might be. But it's a mistake to leave it as an assumption and make decisions based on that. And it should be a simple matter to ask your patient, what is your diet? Are you eating a high-salt diet? Are you missing your fruits and vegetables? What is your specific situation? Be it genetic, biologic, cultural, behavioral. Move from the assumptions, use that as a prioritization to know what to look for, and then confirm it on an individual basis.
Good point. All right, this has been a nice introduction to a number of the issues that we'll see in some of the other cases. So let's move to case 2. Here we'll ask, who's at high risk? In this case, the patient is an African-American male who's in for a routine physical exam. The provider suggests that he begin screening for prostate cancer earlier than age 50. Let's take a look.
Mr. Jackson, I see that you've recently turned 40. Since you're African American, we're going to start your prostate cancer screening this year.
Well, I thought you didn't have to do that until I turned 50.
For many people, that's correct. But in your race, there's a higher incidence of early onset prostate cancer.
But I thought early screening was only for people with prostate cancer in their family, and no one in my family has it.
You're right. People with a positive family history do need early screening, no matter what ethnic group they're in. Both race and family history can give us clues about someone's genetic risk for disease. In your case, even though your family history is negative, just being African American puts you at higher risk. So I strongly advise that we start screening now.
I think the first issue we should address here is the provider's recommendation to begin screening at age 40. Charmaine, you've published on this issue. What are the current recommendations about prostate screening?
Well, there are different schools of thought on what we do in terms of prostate cancer screening. I know the American Cancer Society has recommended that men of African descent should be screened at about 45 in terms of the start of screening, start screening at 45, and men with a family history probably earlier. So it's interesting that this physician recommended screening at 40, even without talking about the family history. So part of my concern with this case is the lack of discussion with the patient about why it might even be useful for him to start screening this early, and the recommendations that are out there actually incorporate this whole thing about discussion with the patient, so that the patient isn't left thinking, just because I'm a black man or I'm an African American man, then I need to start screening at 45, or at 40, really, as you recommended.
That's an excellent point, that especially in this era of patient-centered approach and evidence-based medicine, what would have been nicer to see in this vignette was, instead of the provider saying, it's time to do it, instead say, here's some things that we need to think about. You're black. We have good data that shows that people of sub-Saharan African descent get prostate cancer at an earlier age, in the young 40s, that the cancer is more advanced frequently when it's diagnosed, that it's more aggressive, and that in general the outcomes are poorer. And therefore, it might make sense to start screening you earlier. And our guidelines tell us, in your situation, based on your ancestry, your culture, your race, whatever we call it, the guidelines say 45. And then we layer onto that the family history. And the guidelines tell us with one affected first-degree relative, doesn't really change it much. Whether African American or not, with one affected first-degree relative, we start around 45. 2 or more, then we move it to 40. So here this highlights another problem for the average practitioner. There's a lot of guidelines out there. And frankly, it's hard to remember all the specific details. So I give this provider credit for recognizing the need for early screening. He missed on the exact age, or he failed to get enough information to correct the proper age, or identify the correct age at which to begin. But he's paid good attention to both ancestry, well, at least to ancestry and the need for early screening, and we'd like to see him pay more attention to family history as well.
Charmaine, in the first case we heard the terms Hispanic and Latino, and in this case we heard the term African American. Are these examples of the muddled concepts that Francis Collins referred to in his introductory comments?
I think they are, Joe. They absolutely are. I think the program, we titled the program Race, Genetics, and Healthcare, but we talked about Hispanics earlier, and the census describes it as an ethnic group. And then the African Americans and the others are races. And what's the distinction between these groups? What are these groups really? And for the most part, I think we're talking about ancestral groups, but it's critical to realize that there is so much diversity within those groups. This patient could have said, I'm Jamaican, which is what I often say when people talk about being African American, and the ethnicity that you ascribe to, or where you grew up, and the practices that you engaged in certainly have a role in your predisposition to disease or your health outcomes. So it's the need to recognize diversity within a group and not just make an assumption based on a phenotype, an assumption about the biology or about the practices based on the phenotype, which is what race tends to do. It's not just biology that we assume to be homogeneous. We assume everything to be the same, that these people eat the same food and they do the same thing. So it's critical to recognize that diversity.
So these are not monolithic groups.
They're not, absolutely not.
And that brings out again the gene and the environment. Mm-hmm. So the studies are showing there are genetic variants, there are mutations in genes that we have a good idea predisposed to prostate cancer at an earlier age and of a more aggressive type. And we have data suggesting that some of those variants are more common in blacks or people of African descent. Mm-hmm. But we also have great data about dietary factors. And we don't have enough data, I don't think yet, about cultural variation and how that ties in with diet, and how that then ties in with explaining some or a large part of these racial, ethnic, cultural variations in the frequency of disease. And of course, we shouldn't be limiting this conversation to prostate cancer. That's our example. But it's going to occur in every complex, common disorder that we think about. There will be genetic predisposing factors. There clearly are going to be environmental factors. And the associations with groups will have to do with all of that, not just one or the other. And again, if you're not in that group, you're still at risk.
Right. And I think one of the things that I got the sense of that interaction that you alluded to was that a certain sensitivity about being treated differently. And so, although clearly the provider was well intended, I think there was a reaction as to, okay, you're black, you're going to be treated a certain way. And let's face it, historically, that's not necessarily always been to the benefit of that person of color.
There's a huge stigmatization here.
Right. And so that's the thing, is that you wonder when you're grouped like that, does that mean that somehow the care is being compromised, or I'm being treated in the best way for me? And so I guess I heard that in that comment about that reaction and response. And I think particularly for something that involves this surveillance and quite frankly some of the testing that's involved, some of it with the rectal exam being relatively invasive, if you will, to have a good rationale of why this is being done. And just my race as a rationale may not be very satisfying. And so I think clinicians have to be sensitive to the fact that when we use these categories and we're using a management plan based on that category of race or ethnicity, that we need to be, again, in communication, as you pointed out, with the patient, that this is something that really is toward their benefit, and to really, again, convey the usual things that doctors do in terms of saying, I'm here for you, and what's best to prevent you from having something that, in general, particularly affects people of your race and ethnicity. But at the end of the day, it's about you and what's best for your care.
Right, I totally agree. And I, at least in my practice, try to be sensitive to that. Right. So clearly there's not many people that walk into my office requesting a rectal examination. It's usually not a patient's favorite part of the exam.
That's right.
So when I'm recommending that we start it earlier,
right,
I feel obligated to justify and say, look, I know you don't like this. Quite frankly, it's not my favorite part either.
Right.
But I think it's going to do you some good, and here's why. And I'm not stigmatizing you. And I'm asking you to trust me, but I'm telling you why you should trust me and why this is to your benefit.
Yes.
Or at least we hope it is, and we think it is.
Absolutely.
So let me just try to summarize here a little bit by asking you for some guidance. We've talked about the importance of bringing clinical experience to bear on the guidelines that are in the literature, and some of the guidelines are conflicting, so we have to draw on your experience as professionals to interpret those. But here's what happens in the press, and it's been in the public press, and it's been in the professional literature. We have people who say, for example, there was an article by Sally Sattel in the New York Times that said, I'm a racially profiling doctor. I just do this. It's important for me to know something about the racial background of my patient because it gives me cues about predisposition and so on, and perhaps response to medications. And then on the other side of the ledger, we see statements in the press and in the literature saying this is entirely inappropriate and the biological assumptions are flawed, and if we go down this road, we may be practicing poor medicine. So, do you have any guidance for your colleagues?
Well, I guess my initial reaction is whenever there are polemical arguments, usually probably the truth is somewhere in the middle, that certainly considering race and ethnicity, as I think we've been discussing, is appropriate within context, that we have either epidemiologic data or clinical study data that indicates that there are these different patterns that exist based on race and ethnicity. I think that's just part of the whole database that a clinician has to put in context. I think what's problematic, as has been pointed out, is when the blinders come on and we put people in boxes and we start thinking about certain diagnoses and excluding others without taking in the totality of evidence. And at the end of the day, the race ethnicity is just one element of a total picture we're trying to create about our patient. And as we've discussed, we'd like to dig even deeper in terms of, again, not making assumptions, but things about the diet or behaviors or beliefs that may align with race, ethnicity, but being open to the fact that it's not a monolith. It's not something we can stereotype and generalize about. And that's what's implied sometime in the term profiling, is that we make these presumptions without using that as a cue to then dive deeper.
You know, there's another factor at play here that I'm sure we're not going to solve, but I believe we should at least acknowledge. And that is that I don't think most providers intentionally put on those blinders. But in the real world, the average provider has 10 to 15 minutes from hello to goodbye with their patient. And we've just spent 10 to 15 minutes discussing all the issues, or some of the issues, that need to be thought about. We probably haven't given fair time to it. So how does the busy provider do this? And I don't have an answer to that question. But maybe when an issue like this comes up, it's worth scheduling a separate appointment with that patient just to talk about the prostate cancer screening or the cardiovascular disease risk or whatever it is, and take those blinders off intentionally and say, well, look, here's what the data shows. Here's what argues that we need to do more, and here's where we don't know what to do yet. Here's what it means for you if you choose to do it. If you choose to not do it, here are your choices. What do you want to do? And maybe scheduling some separate time to deal with it can help us all be the kind of healthcare provider that we really want to be.
That's absolutely true. We talk about personalized medicine, and that's exactly what Gary and Howard are talking about here. But in some people's minds, personalized medicine is stopping at the group level in terms of race, and there are examples of that in terms of the group being the person, in other words, and what personalized medicine means going below that, below the group, but as Gary said, digging deeper and not stopping at the group level.
Excellent. All right, let's move on to case 3. Here we're going to look at an adverse reaction to the use of a sulfa-containing antibiotic in a man who has urinary tract infection. This case also presents several concepts related to human history and the evolution of human populations. Let's watch.
Mr. Romano, how do you feel now that you've finished taking the antibiotic?
Well, the burning and other urinary problems are gone. But I just feel tired and achy all the time now.
That's actually not very surprising. Your lab work this morning showed that the urinary tract infection is resolved, but your blood count is down compared to a few weeks ago. I suspect you've had a reaction in which your blood cells are prematurely broken down, causing anemia. This is probably due to the combination of the infection and the antibiotic that you took for it. Your ancestry is Mediterranean, right?
Yes. My grandparents are from Italy and Spain. Why do you ask?
I'd like to test you for deficiency of an enzyme. It's called G6PD, which can cause this kind of reaction. You know, it's fairly common in people from Asia, Africa, and the Mediterranean.
The best evidence we have at present is that modern Homo sapiens arose in Africa about 100,000 years ago, at which point there may have only been 10,000 founders, and we're all descended from that common set of ancestors. So we're all part of the same species. We all have the same set of genes, but each of us has different variants of those genes, about 0.1% of our DNA to be exact, that differs between people. And some of those variants can be important in terms of predisposition to disease or adverse reactions to medications. So that's the medical importance of understanding human variation. Now, as people migrated out of Africa in various migrations to Europe, to Asia, gene flow, genetic migration occurring, these variations got spread around in different ways. And one consequence of that is that some variants are more common in one part of the globe and some in others. In many instances, that's just because of something we call genetic drift. That is, the variants weren't positive or negative in terms of their benefit, but just by drifting, they got more common in one place than the other. So if you look at a particular spelling difference, you might find it at a 40% frequency in Asia, and a 20% frequency in Europe, and a 30% frequency in Africa, and that wouldn't be surprising. But if you look between populations and say, how much of the genetic variance is actually accounted for by the fact that this population is over here and this one's over there, it's actually a pretty small fraction, only about 10%. Most of human genetic variation is in fact found within whatever group you look at. So the similarities between groups are actually profound, and the differences are relatively modest. Now, in some instances, a particular variant has actually provided an advantage to those who carry it. For instance, individuals who carried variants in certain genes where malaria was common, when those variants provided protection, were likely to survive and therefore to pass those variants on. And so, for instance, particular variants in the hemoglobin genes, such as sickle mutation or thalassemia, or in other genes like the G6PD gene, allowed individuals to do better if infected with malaria. And so those have reached a high frequency in parts of the world where malaria was common, but not so much in other parts of the world. So the bottom line is, we're all a lot alike. Genetic variation is only 0.1% of our DNA. There is some variability in terms of what you see in different parts of the world, and some of that may play a role in why some groups are more at risk or more protected for a particular disease. This makes it important, as we're doing biomedical research, to use defined populations so that we can understand the effect of genetics and environment and be sure when we make an inference whether or not it can be extrapolated to other groups.
Dr. Royal has been working on genetic variation in a variety of populations, and she's been studying the relationship between genetics and race for quite a while. Charmaine, I want to ask you in just a minute to summarize for us some of the most important points from Dr. Collins's overview here. But before that, perhaps we should clarify what Dr. Collins meant by spelling errors.
Well, he was really talking about differences and changes in the DNA sequence. Our 3.1 billion bases of the DNA sequence, there are changes and differences from individual to individual. So that's what that is, the changes in the sequence. In terms of some take-home points from what Dr. Collins said, I think one of the key points, which really shapes the way we think about genetic variation, is this common origin of Africa that population genetic studies have shown. And because Africa is the birthplace of humankind, there's variation, and populations moved out of Africa to other parts of the world. And the different biological and environmental processes that operated in these different parts of the world determine the frequencies that we see. So when we see differences in these geographic ancestral populations, which is pretty much what we're talking about when we use these categories of African American, European American, we're talking about the geographic regions from which people came. And we see these differences in frequencies. So the way we think about populations shouldn't be in terms of the presence or absence of a particular allele or variant, but more in the frequency, the differences in the frequencies from one population to the next. And when we look at these differences in frequencies and we see differences in populations, the question that many people ask and the way we've been conceptualizing these is are these groups races, the groups we call races? Are they races? What are they really? And the whole issue of the definition, and if we use a taxonomic definition of race, which talks about race, which is a biological term.
With a specific mathematical criteria.
That's right, exactly. We're talking about a certain amount, a certain degree of biological divergence below the level of the species, which results in groups that have certain genetic characteristics that are different from, and that all the people in those groups have, that are different from another group. And even though people, when they talk about race and they use the term race, many people are not thinking about the specific taxonomic definition, but we treat these populations that way. That is just how we treat them. And the question is, do we continue to refer to these groups as races and treat them as races, or do we use more specific and more accurate terminology that really get at what we're trying to say? So the message here is that there is variation. There are differences in these groups that we see, but these groups are not races in the technical sense of the word.
And the variation in the human population really is continuous pretty much around the globe, and we don't see hard and fast discontinuities in the frequencies that would allow us to draw precise boundaries, for example, between where white ends and black begins.
That's right, absolutely. And people move, and people mate with whomever they want to mate with.
That's right. We've run that experiment.
Absolutely. And then the other thing, too, is that we know, because, as you said, variation is overlapping it is overlapping, and we talk about the continuous nature of variation that makes us realize that these groups are not discrete groups, but there is overlapping variation. But what we really see when we look at genetic variation is a nested pattern of variation. Africa, as the founding population of humankind, harbors the most genetic variation. We've seen that. Interpopulation genetics has shown us that. There is more variation in African populations than other populations. But the variation that we see in other populations is only a subset of what we see in Africa. We talk about only about 10% of the variation that we see being unique to any one population. 90% of that variation is found in all populations. But even though we may find variance in African populations that we don't find in other populations, not everybody in those African populations have those variants. And that is what we need to communicate, which also dispels this whole notion of race. Because there may be variants there that we don't see in other populations because of the age of African populations. But not everybody in the population has that. And so it blows the whole notion about these homogeneous groups out of the water. It really does. And when we start conceptualizing groups as being mixed up, in other words, I think we'd start treating them a little differently.
Yeah, that's a good point. Other comments, questions?
Well, I guess I was intrigued also by the example of the case in which here was this genetic spelling change, if you will, a variant, and it appeared to transcend our usual racial boundaries. This is a deficiency often found in African Americans, but as shown in the example of the case, also could be found in people of Italian descent or Greek descent. And so clearly it was the shared environmental experience in some ways in terms of their ancestries in that region, exposure to malaria, that really trumped our usual categories of race. And I guess that's one of the promising or exciting things, again, about genetics and genomics, is that hopefully we can find those markers that explain clinical phenomena, just like illustrated in that case, that go beyond just the superficial of race, and in fact bring us to understand things that are throughout the human family.
I'd like to actually elaborate on that a little bit, and it brings up another, I think, very important genetics concept, which is, as we've heard several times now, that most of the variation is distributed across groups, only 10% within groups. And in fact, that variation is only 1/1000th of the entire genome. So it's a small amount of variation, but it's big enough to count. But another important genetics concept to add on top is the importance of any one genetic change. So we've known for many decades now that there are individual genetic disorders due to a mutation in a single gene that can cause profound effects. Sickle cell anemia, G6PD deficiency, the list goes on. They're individually rare. Take them as a large group, and they're common enough to be major contributors to disease. But in any one condition, metabolic syndrome, prostate cancer, they're going to be relatively minor. This leaves us with the remaining most of that 10% variation within groups. That's not going to be a single gene causing a major disorder, but is still important. And this is the genetic contribution to common complex disorders. Asthma, high blood pressure, etc. There isn't likely to be one single genetic change causing it. There's going to be 4, 5, a dozen or more specific genes that up or down regulate the processes that have to do with health or disease. And there are going to be multiple minor contributions from many of them. And these are the variations that are likely going to turn out to be important between one group and the next, but it's not between. It's more frequent here and less frequent there, but the other one became more frequent in the next geographic population. So we have these continuous changes across the globe. And the complicated job before all of us is to prioritize it and determine what to do with it.
Well, let's take this into a specific clinical question. We've got a question here that comes from Los Angeles, which has an enormous amount of ethnic, racial, whatever kind of diversity we want to call it, and it has a real clinical relevance. The question is, do genetic tests like Factor V Leiden or BRCA for breast cancer have the same clinical utility in all ethnic groups? If there's all this admixture within groups and they're not monolithic, what do we do with those test results?
That's a great example of the point I was just making. So if we look at both of those one at a time, factor V Leiden is a very narrowly defined condition. The presence of that variation in the factor V gene specifically increases the risk of thromboembolic disease. You have that genetic mutation or you don't, and it is very narrowly defined. We could expand that definition a little bit and call it resistance to activated protein C, and that makes it a slightly broader category, and then that test is slightly lower in clinical utility, but it's still mostly a yes or no question, much like sickle cell anemia or G6PD deficiency. You have that genetic change or you don't. So in that case, the utility is good across ethnicities, but it's more common in some ethnicities than others. Whereas with breast cancer, here's a common complex disorder. We know that some percentage, maybe 10% or so of breast cancer is hereditary or familial, but only a small fraction of that will be due to a single gene, and most of that will be due to multiple genetic and environmental effects. And there the utility will vary, and even within that, we know of multiple different BRCA gene mutations. So in Ashkenazi Jews, we have 3 mutations we can start with and test those first. If those are positive, we're done. If they're negative, we go to broader screening, and even that won't give us all the answers. So in this case, there are ethnic differences, and our yes or no answer is not absolute and requires more interpretation.
I think one of the other elements that that question brings out is that, as you alluded to, that, for example, factor V Leiden, the frequency of that at-risk marker is different in different populations. And so certainly if clinicians facing the thrombotic risk of someone who seems predisposed to blood clots, in an African American, there's a relatively good chance it'll be negative for the factor V Leiden. Given
Absolutely, very low frequency.
Very low frequency. And again, I think that's one of the challenges that comes about that for further research in some sense is that we would know that in terms of the biology of the predisposition to thrombosis, that's probably going to be true of all members of the human family. And one of the challenges is that maybe the characterization of a given allele or a given marker has been done in European populations for a lot of reasons, that we still may need to do some more searching for similar alleles. It actually could be at the same factor V locus that could have the same sort of predictive utility for an African American patient who's at thrombosis risk as factor V Leiden has proven to be useful for people of European descent. So we have some opportunities to not only recognize the utility in these different ethnic populations, but also to expand the repertoire of tests that clinicians can use in different ethnic populations, maybe different markers in some contexts.
Absolutely. Can I reemphasize another point that came up as well? Again, genes are not destiny. So to have the factor V Leiden mutation does not mean you're going to get a blood clot.
That's right.
And we don't even have good data yet to know what is the real frequency. We have relative risks, but we don't have absolute risks.
Right.
I don't know what to tell my patient who turns out to have factor V Leiden and has never had a clot.
That's right.
I say, watch out for clots.
That's right.
So we pay more attention. We're careful around surgery. We try not to stay in one position for a 5-hour plane ride. But we really don't know exactly what it means. And even a BRCA gene mutation, the risk of breast cancer is high, probably 80% across the lifetime, but 80% is not 100%. And indeed, there are interventions that can reduce that risk.
Excellent point.
So just to reinforce, genes and destiny are separate things.
So I want to ask one more question before we go on to the next case, but let me use this as a reminder to our viewers that the phone lines are open and we're ready to take your calls. The toll-free number is 800-842-2032. So here's another question that came in just a while ago. This is from Kansas. Many of my patients have single parents and don't know or won't admit their racial or ethnic backgrounds. So Gary, should the clinician take seriously what his or her patient has to say about family history?
Well, again, I think first I would just say that it's important to elicit from the patient their sense of their ancestry. I think there's a tendency, because we've all been trained clinically, to write down what the physician perceives or the clinician perceives as the person's race and ethnicity. So I think there's some value in eliciting that information as how the person identifies themselves. I think there's actually some information in that, and not necessarily. So a reluctance might be to avoid being put in a box. And so for them to express how they feel about where their origins were, and even to ask them about their parents, recognizing that in some cases they may not have that information. The other piece, I think, implicit in that query is that sometimes there's been a reluctance in some cases to ask that information. So I guess I would be encouraging.
Why is that? Let me ask you.
Well, I think that sometimes, I think this is not specific to any ethnic population, but we often don't know, well, what did happen to Grandma, and why did she pass, and so forth. And I think, as many are aware, the Surgeon General and the Centers for Disease Control are very much interested in an initiative to encourage people to delve into their family history. And that's, I think, potentially empowering in terms of understanding what is it that kind of runs in our family. And so sometimes the patient won't know, but it may be a challenge and opportunity for them to probe and find this information out. So I think that's one opportunity that raises.
So let me just point out, following up on Gary's comment, that the Surgeon General actually, in conjunction with a variety of groups in the federal government, has developed this very nice family history tool. It's available online, and it's available in Spanish and in English. And the opportunity here is for patients to take some time to focus on their own family histories in their comfort of their own homes and collect the data before they go in to see their clinicians.
That's right, because as Howard pointed out earlier, the physician only has so much time. And so the more they have ahead of time, the better it will be, because information is critical.
Yeah. So that tool is available at cdc.gov, actually. And although one fills out the family history tool online, the information does not stay on the government's website. It's entirely protected because they're sensitive to confidentiality issues. So,
and again, I was curious, actually, because I know Howard works in this area in particular. What is your sense of the reliability of that information?
Well, actually, we have some good data. This has been studied in a number of different areas, especially cardiovascular disease, but really in a number of areas. And the data is encouraging that when a patient comes in and says, here's my family history, that's usually pretty accurate. So if they say something exists, that probably does exist. And if they say something definitely does not exist, it probably really does not exist. So it's good. It's at least 50% correct in the worst case. And many studies are showing 80–90% accuracy, both for correct information and correct absence of information. What's not listed is probably not present. So the data is good and it is reliable, and I encourage that to be used. I would add a couple more points, though, and that is, again, providers are very busy, so yes, it helps if the patient brings in the family history information. But this is information that needs to be used throughout the entire duration of the doctor-patient relationship, whether it's 1 year, 10 years, or the full lifespan. So it's not collect it once and set it aside. It's collect it, update it, maintain it, and use it as needed. And therefore, it doesn't have to be all done at once. So if in the first visit you get what the patient brought in, and you spend 90 seconds reviewing it briefly, and on the next visit you elaborate, well, did you learn more about Aunt Sally and Uncle John? Were there any other health problems? Did you figure out, so stomach cancer, I should have clarified this. Stomach cancer is the one area that's often wrong. So if a patient comes in and says my relative had stomach cancer, oftentimes that is some other abdominal cancer. Occasionally it's truly gastric carcinoma, but in women it's often ovarian or some other gynecologic cancer, and even in women and men, really, colon cancer is common and other abdominal cancers. So that deserves clarification, but we can again spend time on multiple visits completing that family history. It doesn't have to be all done at once.
Good point.
All right, thank you. Let's turn to case 4 now. Here we explore race-related issues in the use of BiDil. This is the first drug approved by the U.S. Food and Drug Administration for use in a designated racial group. The presenting patient in this case is a 60-year-old African-American female with heart failure, and the provider will discuss with her the reasons for prescribing BiDil rather than another drug. This patient has recent onset of heart failure, and the provider is following up. Let's watch the case.
Well, Mrs. Jones, in the past few months, we've added digoxin and maximized the beta blocker and diuretic for your heart failure. Has that helped any?
Well, I'm not short of breath sitting at the table, but I can't get up the steps or walk much past the mailbox without stopping to rest.
So it sounds like you still need more medicine.
I'm already on so much medicine. Can you try to make this the last one we have to add on?
Well, we have some interesting options here. ACE inhibitors are very beneficial in many patients, but sometimes don't work as well in African Americans. There's now data to suggest a combination medicine called BiDil might be particularly useful in African Americans with heart failure.
I heard about that, but I don't want any medicine based on the color of my skin. Why don't you give me the good stuff?
Well, the truth is, we don't know for sure what the best choice is for you. What we do know is that both types of medicines are good, but there appears to be a difference in the way different races respond to them.
But what makes you think I'm like all of the other black people out there?
I don't. But as you've already said, we'd like to do this with as little medicine as possible. Of course, we can always make a change if the one we choose doesn't seem to help.
Do you give this medicine to white people?
Sometimes, yes. But for the same reasons we just talked about, ACE inhibitors might be better in that group.
Okay, I'll give it a try. And we'll see what happens.
BiDil has received an extraordinary amount of attention in the lay press and in the professional literature. This one decision by the FDA and the attendant discussions around that decision seem to have crystallized many of the disagreements and conversations about the use of race in healthcare. Gary, you're a cardiologist. Do you think it was appropriate for this provider to suggest BiDil for this patient?
Well, as we start at the top, some of these cases are illustrative and not necessarily best practice. I must say that in my experience, that for a patient like this, who was on diuretics and digoxin and a beta blocker, that most guidelines would also emphasize the use of a drug to block the renin-angiotensin system. So either an angiotensin-converting enzyme inhibitor or an angiotensin receptor blocker. So this individual really should be on one of those renin-angiotensin system blocker drugs. The actual trial that was part of that indication that the FDA approved was in patients who were already on that background therapy of being on an ACE inhibitor. So you had a trial of African Americans, over 1,000 that were studied, who were already on beta blockers, ACE inhibitors, and diuretics. And the study was a comparison of this new drug, BiDil, compared to placebo. And BiDil was shown to be very beneficial in a convincing way in reducing morbidity and mortality in this African American population. So because of that study, it's clearly a compelling addition to our armamentarium. However, the patient really did ask the clinician a very insightful question as to this notion that it's a black drug. And I think that's one of the challenges here, is that study, we have to recognize, was only done in African Americans. And so, although we know it's effective, there was no comparison in that prospective study of looking at BiDil in an African American population in comparison to whites in the same sort of parallel design. So it's really not possible for us to conclude that BiDil won't work for whites who have a similar form of cardiovascular disease or heart failure as the African American. So I think it's a bit of a misconception, really, of what the study actually showed and what we can really conclude. Clearly, she had some trepidation about being prescribed a black drug. And I think we have to be sensitive as clinicians that, again, when our management is being, in a sense, dictated by these racial categories, that we're taking population information and applying it to an individual patient. And at the end of the day, she wants to be treated as an individual. And this is one of those instances. We know, for example, in hypertension, if you give an ACE inhibitor, on average, yes, let's say people of European descent may have a 10 millimeter drop, but on average, maybe African Americans will have a 7 millimeter drop. Yes, there's a mean difference, and people may say, overall, it's more likely to work in whites than blacks.
But you need the ACE inhibitor there.
In the ACE inhibitor,
okay.
Exactly. And yet, but that's on a mean basis of the populations. If you look at it, though, there's a overlap in those bell-shaped curves, and so there are African Americans who will have a profound response to an ACE inhibitor, and there's some whites who have a relatively blunted response. So it's clear that once we go again for these group means back to the individual, we really can't say that she won't respond. And indeed, she's already on a diuretic. And so when studies are done to say, what happens to a group mean once you put them on a diuretic, actually the differences between the racial categories tends to melt away. So in point of fact, there's a very good chance that she would respond well, and most of the clinical trial data, including that forms the basis of BiDil, would make the presumption that she should be on an ACE inhibitor. And so, but I think it does kind of reemphasize how when these studies are done and there's a lot of discussion and press coverage, that things tend to get polarized in these racial terms that really cloud us from really taking care of the individual patient as well as I think we can.
Right, and in following up on that, Gary, it really prevents us from looking at the mechanism of action of the drug, because there's the hypertension, which is a factor that may influence how people respond to the drugs, regardless of what group you're in. That's right. And so it may have made more sense to select the group based on their hypertension, their blood pressure. So the whole issue about how you select your group, yes, and what the criteria are that you use to determine what you're going to study to look for what effect is absolutely critical.
In these studies, I think we need to be clear. The study, the AHEFT study that was used to go before the FDA, was not designed to ask the question, do blacks respond differently from whites or other groups when given hydralazine and isosorbide dinitrate? The question was, when added to standard therapy in this group, does it work? And the way the FDA process is set up currently, they will grant approval for whatever group was studied. And we're only starting to recognize now. Really. Well, that's true. So that's just what I was going to say, I think. Correct me if I'm wrong. But we've had the problem in the past of studying generally white men and then extrapolating that to men and women across the globe. And so fortunately, there's finally some recognition that not everybody on the planet is a white man. So now we're starting to see, perhaps this is the beginning of a new method of approving medications, that they're approved only for the age or sex, gender, race, ethnic group in which it was studied. And we need more studies. I would love to see that comparator study. Take people of multiple races with equally controlled blood pressures and ask the question, do blacks versus whites versus Asians versus whatever other group respond similarly or differently when this combination of medicine is added on? And then and only then can we start asking the question, is there a difference? And then if there is, then we can ask, is it a genetic cause? Is the pharmacogenetics involved? Are there variations in the genes that metabolize these drugs that truly correlate with that effect? Or is it cultural and behavioral? Is it the diet? Is it side effects? Am I more prone to have a cough or an angioedema as a reaction to an ACE inhibitor and therefore can't take it? So we're not even ready to answer that question yet. We first have to ask, is there a difference? And then we can get at what is that difference.
Charmaine, something curious seemed to happen here with the discussions about BiDil and the treatment of BiDil in the press. We've just heard that there was no reference to genetics in any of the studies that led to the approval of BiDil, but somehow race and genetics got conflated in this discussion about this drug. What happened here?
Well, you know, Joe, there are some people who do say this is not a case about race and genetics, that people just assume it is. And in my opinion, it is a case about race and genetics. And I think the problem is that it is so ingrained in our thinking that we don't even see it. Because genetic information was not collected, then we just assume that it wasn't there. But it's implied that the genetics is the same. And that's why it wasn't collected, in my opinion. And it's implied that the cultural practices of the people in this group are the same. So we don't need to look at that. So because we've got it covered. In the paper that was published on BiDil, there's a quote at the end of that paper that I find very interesting, which for me really gets at the perspective that was brought to this study. And it talks about rather than studying a large heterogeneous group, we chose to study a group in which the genetic and environmental factors were more likely to be, were easier to identify, I guess, or we could better control for these things. And that is the thinking, why we just didn't collect that information, because it's assumed it's the same or it's very similar, so those differences, we don't really need to dig deeper to find what those are.
I agree that I think there's several racial issues as undertones that often just don't get thought about. And it may be instructive to look at other examples and take the black-white out of it So we can look at alcohol dehydrogenase and sensitivity to ingestion of alcohol. And we've known for a long time that Asians have a higher frequency of that genetic mutation. But we also know that you don't have to be Asian to have that sensitivity. And we have recent information that certain medications, certain cholesterol medications, certain chemotherapeutic medications, perhaps have different effects in Asians and perhaps need to be dosed differently or avoided. And we can move out of races and ethnicities and talk about sex differences. So we have a drug for constipation predominant irritable bowel syndrome, Zelnorm, and it's approved by the FDA for use in women with constipation. It is not approved for use in men. My understanding is that's simply because not enough men have been studied, so the question hasn't been answered. And then, of course, there are off-label uses, which we are not here to endorse or comment upon. So, but that's another good example. That's hydralazine and isosorbide, to bring it back to our case. Can be used in anybody, have been on the market for decades, were studied in the first VHAF trial, and shown to be no better nor no worse than ACE inhibitors. I take that back than some of the other drugs. But eventually we learned that ACE inhibitors were a better choice in VHAF2. So it's complicated. There's a lot of data out there. It's not one group. This is not a black drug or a drug not for Asians or a drug just for women or not for men. It's what does the data support now?
That's right.
And we're still waiting for more data to learn how else to use or not use these drugs.
Right. So I don't want to leave this case without coming back for a moment to the interaction between patient and provider here. Black female patient, white male provider. Let's talk about that interaction a little bit and things that might be important to clinicians as they consider those kinds of interactions.
Well, I was concerned that at the end, she had a sort of reluctant sort of body language. She consented, but it was clear she was not fully engaged.
She wasn't happy about it.
She wasn't too happy about it.
So will she take that medicine?
So exactly, Howard. I mean, I think that's the question. If at the end of the day we're trying to be sure that she's on the best regimen that's going to improve her life, that she needed to be more engaged in that. And I think I got the sense that she was going to do this very reluctantly.
Which just, I'm sorry to interrupt,
Sure.
but which for you implies a lower likelihood of staying on the regime.
I think that would be very likely, whether it's side effects or just commitment to doing it or the copay or whatever it is, the patient adherence to that regimen, I think, was compromised because in that dialogue, in that interplay, there really wasn't a partnership there in which she bought into why she was on this drug. And I might say that I think by premising it again as you're in this box, you're African American, this is the drug for you, that in a 60-year-old who probably grew up in a time of segregation and so forth, that things that were designated for blacks weren't always the superior ways to go. And so I think she may have read into this, that this was something, she wasn't getting the white drug, and maybe that's really what she wanted, because that was, in her mind, perhaps the good one, the better one. And I think that just working through that and having sensitivity to the fact that once you went to that category and had that stigma attached to it, she was probably not going to buy into it for a number of reasons without more fully explaining why, in fact, this was ideally suited to her. And it could have been, going back to a study was done of people who look just like you and share many characteristics of your kind of heart failure, and put it in context.
But in fact, the provider was trying to convince her of the wrong thing, as we've discussed.
Yeah.
That what he really needed to convince her was, I know it's a lot of medicine.
Right.
I know you don't like taking all this medicine.
Right.
And here are the studies that show why we know it's in your benefit
That's right.
to take all these medicines.
That's right.
And that's why I want you to take this ACE inhibitor.
That's right.
And the race issue doesn't even need to come up in this case.
Yeah.
But she does need to be convinced.
Good. This is great discussion. Time constraints require that we move on. So let's take a look at the next two cases. They're very brief. Each emphasizes the importance of family history and patient ancestry. In case 5, a couple requests preconception carrier screening for Tay-Sachs disease and other conditions found more commonly in Ashkenazi Jews. Here's case 5.
Mr. and Mrs. Christensen, I'm not sure that it makes sense to do this screening test, being that one of you is Mexican American and the other is Northern European.
Well, even though I am Mexican American, I am part of a large Jewish ancestral group that originated in Spain.
Okay, but still, Mr. Christensen, my understanding is that you're not Jewish, right?
No, I'm not, but I've learned that both of my grandmothers were originally from Poland, and we don't know if they were Jewish or not.
Oh, I see. Why don't we take a look at this in a little more detail?
Howard, how'd the provider do here?
Here's a case where I think our patients did a lot better than our provider. So for whatever reason, the provider felt that this was a couple who didn't need to worry about Tay-Sachs or other diseases found in Ashkenazi Jews. The name Christensen certainly does not elicit visions of an Ashkenazi Jew, and the people in front of us certainly don't look Jewish. That's a very important point. You can't determine someone's genetics or behavior or culture based on a name or the way they look. So our patients needed to convince the provider that yes, they are at risk for these conditions. So good for them. I think they must have gone to the Surgeon General's website and done that tool and figured out what they need to worry about. So the lesson there is don't forget the family history, don't forget the ancestry. That's in a nutshell.
Absolutely. Well said, Howard. I agree completely. I think those are the main points here, I think.
Okay. In case 6, the patient is a 48-year-old man of Filipino descent. This gentleman presents with fatigue, diffuse pain, impotence, and reduced libido. A previous provider told him it was probably depression. Physical examination was normal. Let's take a look at this case.
Mr. Hernandez, you've told me that your brother has diabetes and joint pain, and that both of your parents are from the Philippines. Your symptoms may be due to hemochromatosis or a related iron overload disorder.
Really? What makes you say that?
Well, iron overload, among other things, can cause joint pain and hormone problems that can explain your symptoms. Hemochromatosis is mostly seen in people of Northern European descent, but similar iron overload conditions are common in Asians and Pacific Islanders.
I'm guessing that most providers wouldn't have included hemochromatosis in the differential diagnosis for this patient. Gary, what do you think?
I'd agree. I'd give kudos to a very astute clinician. Those were a rather broad set of symptoms that a myriad of diagnoses could have been made in that differential diagnosis, and to include hemochromatosis was pretty remarkable. Particularly, I think a lot of us who go back to medical school, we tend to think of people of European descent of having that, and that's where a lot of the genetics has been characterized. I guess for me, it was noteworthy that he appeared to appreciate the fact that a lot of these same disorders, or at least phenotypes, are found in, again, throughout the whole human family, and indeed recognize that, hey, this constellation, which I classically put in the box where, oh, that's where the European whites get that, can actually apply to this Filipino gentleman. And indeed, that population could also manifest the complications of iron overload. So I give my hats off to him.
I would just bring out again the importance of family history. So it wasn't just multiple nonspecific symptoms. Depression, hypothyroidism, much higher on the differential diagnosis. But to have a sibling with similar joint pain and diabetes, and to associate those with hemochromatosis, again emphasizes the importance of family history. And we also should mention briefly that again, the data doesn't stop coming in. So there was a great study in the New England Journal, April of 2005, that looked at hemochromatosis in racially diverse populations. And its main thrust was to look at the HFE gene, the common Northern European hemochromatosis. But within that study population, iron levels were measured. And indeed, the highest iron levels were found in Asian and Pacific Islander descendants. What is the cause? What is the clinical association? We don't know that yet. But again, good for this provider for recognizing that you don't have to fit the official designated group to be considered for a diagnosis.
Good. Other comments?
No, I think Howard covered it.
Yeah.
Okay. Our last case involves a provider and a medical student. They're discussing patients they'll see that day. This student is on rotation from a large East Coast city, and the clinical setting is in a rural central state. Let's see what they have to say.
I reviewed the list of patients coming in today. I noticed there's several white kids with developmental delay. They all live in the same general area. Do you think they're somehow related and this could be a genetic syndrome?
Sometimes clustering in an ethnic group has a genetic cause. But remember to think about environmental factors and the interaction between genes and the environment. With the kids we're seeing here, it's likely going to be lead poisoning.
But I'm used to seeing lead poisoning in minorities living in the inner city.
Right. But here, our low socioeconomic group at high risk is kids growing up on small farms where the lead hasn't been removed yet.
So what about the student's view of the situation, Charmaine?
Yeah, Joe, I think this case is one that we see so commonly in terms of our readiness to invoke biology when we see an outcome in terms of a particular health outcome. And it really leads us to think about health disparities in different ways and recognizing that there are lots of different factors that go into creating these disparities, and that the differences that we see are not necessarily due to biology, and that something like poverty and SES can unify all of us in terms of these groups that we call race and ethnicity or racial groups. But access and exposures and all these factors influence health outcomes no matter who you are. and I think that is an important message that this case bears out.
I thought it was also sort of poignant, actually, that, and it may be something about how we are trained as clinicians, that the medical student was already, again, putting people in these racial categorical boxes, so that he seemed to be learning somehow that African American, inner city, developmental delay, that's when you think about lead. And I think by stepping out to a totally different context and seeing that same constellation of presentation, but now away from the race, helped him hopefully broaden his conception. So he really focuses on the constellation, the developmental delay, and the potential for there to be this environmental feature without having be programmed in that links that exclusively to a given race, because clearly it does.
Yeah. So why does he mention these are white kids? Why can't they just be kids with developmental delay?
Right.
And that then raises the question, would it even be flagged? Would it be picked up if it was a group where they're expected to perform lower? And we have no data to suggest that there's really any performance or intelligence difference between groups. It's a widely held misconception.
That's right.
So that's very important to acknowledge. And of course, again, it's not all genetic. I've sat here for the last hour and a half and said it's genetic, look at the family history, look at the ancestry.
Right.
It's not always that. Often it's not.
Right.
So here's a case where it's purely environment.
That's
You could argue a tiny genetic component, maybe there's variability in how one reacts to lead poisoning. But most of it is whether or not you ingest it.
That's right.
So there's a lot that has to get thought about. It's a hard job.
Absolutely. That's why we do it.
It's a fun job.
What about the impact of some of these issues on diagnosis? We've seen that socioeconomic status and other assumptions about cultural membership in cultural groups or racial groups can affect diagnosis. Let's talk about that a little bit.
Well, I think it also reemphasizes that a lot of what we've talked about involve situations where there are differences in either health outcome or disparities. This is one of those contexts where this proxy of race is often superimposed upon a number of other issues that relate to, historical factors in many cases, where people of a given race have a certain history of deprivation in terms of their socioeconomic status and their access to housing, and how, in fact, housing and elements of it are treated such that they're exposed to toxins that ordinarily would be having a negative impact on their health. We potentially could have come at this in terms of asthma or other conditions in which the environmental context is really a key either trigger or exacerbant. So there's probably not too much debate that there are genetic predispositions to asthma, but clearly we have to recognize that there are things about the context of certain housing conditions that really exacerbate that and then create a health disparity. And so in addressing that, clearly the genetic part is perhaps useful diagnostically, but we have to consider other aspects of access to things, whether it's access to a quality environment or the food, or access to the ability to exercise. So there are things in dealing with health disparities that we recognize it's really a confluence, again, of the genetic, the biological, but as well as the socioeconomic and indeed policy implications. And so it's hard to deal with health disparities and just talk about genes and biology.
There's clearly bias involved.
Yeah.
So is a woman less likely to get diagnosed with a heart attack when she presents to the emergency room with chest pain? Is a black child versus a white child more or less likely to make the diagnosis or get diagnosed with asthma? And in the field of psychiatry, there's now good evidence that a psychotic illness in blacks is more likely to be called schizophrenia, and in whites is more likely to be called bipolar illness. That may have to do with racial perceptions and what seems like a less onerous or more onerous diagnosis, and where is it okay to put one or the other value on it. The reality is, again, we don't know what's correct here, but there seem to be trends that are not supported by the science.
And again, I guess I'd go back to the medical student. I think we have an opportunity, indeed responsibility, that some of this is conditioned. I don't think clinicians have a malintent, clearly, in some of these situations, but we get sort of programmed into these ways of thinking, and part of it is sort of breaking out of those patterns, where, again, we're thinking beyond the race.
Okay, we have some other questions that have come in here. They're very interesting. Let's see if we can get to a few of them. Here's one that goes back to case 1. And this, I think, derives from Mr. Lopez's statement that he was doomed, or his question whether he was doomed to develop metabolic syndrome or suffer a stroke. How do you address a patient who believes that his genes are part of God's design and plan? It's a tough question. Anybody brave enough to tackle that?
I'll tackle that. You know, that is a very good question, because there are many people who think that way in terms of genetics, and when you give a diagnosis and people needing to decide what they do with that information, their spirituality often comes into play. I think one of the key things that we need to note, and that clinicians need to recognize, is that even as we're talking here about race and ethnicity, that everybody in one group is not going to think that way. So we don't say African Americans are more likely or less likely to use genetics because they're more spiritual. And so the key is recognizing diversity within. But when we think about genetics and as the question says, genes being part of God's plan, I personally believe that genes are part of God's plan. I also believe, though, that when we think about Mendelian disorders, that they're Mendelian disorders that usually we say deterministic genes. You have the genes, you're more than likely going to get the conditions. But I feel that even with those, as well as with multifactorial conditions, there are things that you can do. And when we see someone present with sickle cell disease, for example, we see a range of severity in that illness, some of which is based on interactions with genes, with gene interactions, but gene-environment interactions that in those cases don't determine whether or not you get the disease in many cases, but determine how well you do with this particular illness. With multifactorial conditions, on the other hand, we know for sure that the genes really don't determine the outcome. And in that case, there is more that you can do to modify even whether the chances of even getting those particular illnesses. So I think that even though for many people, there is a spiritual aspect to genes and what we get when we're born, but there are many things that we can do either to alleviate the severity of the symptoms of some of these diseases, but to reduce our risk of getting them altogether. And I think that we should.
It might have been God's plan to give you those genes, but part of his or her plan might also have been for you to consult somebody and get some help.
That's right.
That's actually exactly my answer to this.
That's right.
So I try very hard to recognize people's personal beliefs, their spirituality, how they want to deal with the problem that's presented. When I get this kind of response back, my first question in my mind that I'm not going to ask out loud is, okay, is this just their way of putting me off so that they don't have to take medicine? So I'm going to try to probe a little more and gather more information. Why don't you want to do anything about it? Or is it just that you don't want to take medicine, and can we look for behavioral changes? But ultimately, my answer, if they're truly spiritual, they've passed my test. They're truly spiritual. Then my answer is exactly that. Well, yes, God gave you your genes. God gave you your burden. And God brought you to me and gave me some skills to help you cope with it. So let's work together with God, and talk about what we can do.
Right. And indeed, he also gave them that choice.
That's right.
And so ultimately, that a lot of what we're talking about is genes are not destiny, and we still have an opportunity to make some decisions of the things that we can modify. So I don't consider it necessarily disempowering to have that. And for some people, that can be further stimulus and a source of social support, et cetera.
Well, Gary, we're going to stay with you for a second here. This is a question from your backyard, from Atlanta. I understand that BiDil has had poor acceptance among clinicians. Do you expect future race-based studies and FDA approvals based on ethnic or racial criteria?
Well, I think as we've tried to deal with, there are contexts in which I think Howard articulated very nicely that from the clinician standpoint, there are things we need to study on the basis of race or ethnicity or even gender. That there are things in designing a trial because of observations that have already been made or epidemiologic findings where we might identify a high-risk group. Because as clinicians, we often will target our most aggressive therapies for those who are at greatest risk. So I think it's reasonable to partition these various things, again, hopefully with some biological basis. And so I don't think it's something that will end, and indeed I'm aware of other trials that are underway. What I would hope, though, is that, as we discussed, if we're going to make racial inferences, that we actually do direct comparisons, that we do studies that are appropriately have sufficient number of patients and are called statistically powered, that we can make conclusions about different ethnic groups as to whether it is more or less beneficial in each group. And secondly, again, I look toward the future with the hope that we actually may come to a day in which we would identify, again, genetic markers that might, again, confer risk, where we can go beyond racial ethnic categories and say, are there people who share a certain at-risk set of genetic markers, variations in the spelling of their DNA code that confers high risk, and recognize that that might involve some whites, some people from European descent, African descent, Asians, but what they share in common is this group of genetic variants, and let's target the therapy there with the hope that that's the group that's going to respond best. And again, we'll go beyond the race.
So we've got proxies now, and we want to move toward individual assessment as quickly as we can.
Yeah. In today's environment, we still have to look at our groups because we don't have anything better. But with the HapMap coming out of the Genome Project, the more we learn about genetics and predisposition, the more we ask about cultural and behavioral factors, the more we can individualize the care, and that's really the best for everyone.
Okay. So we have one more question. If there is more genetic variation within groups than between them, why do we conduct so much research on specific population groups? Who'd like to take that on?
I'll start.
Well,
I think.
You go ahead, Howard.
Okay. I think at least I tried to discuss this some already. So we've talked about, Francis talked about the 0.1% variation across all of humanity. There are 3 billion bases in the single copy of the genome, and we have a double copy in every cell. So we have 6 billion bases. 0.1% is 6 million, and we've discussed 10% variation within groups as opposed to between groups. So we're down to 600,000 bases that vary. That's still a lot. So there's enough there that it can be important, but it's not all or nothing. And we've talked about the continuity from one group to the next. So there's still some differences to look at.
Okay. Thank you. I'd like to thank our esteemed panel, Gary Gibbons, Dr. Charmaine Royal, and Dr. Howard Levy for their participation in today's program. And thank you, our audience, for taking time out of your schedules to view this broadcast. To receive CME credit and to help us continue to produce quality programs, please take just a minute more to fill out the evaluation form provided by your site coordinator. If you'd like to see more programs on this topic, please let us know. We value your comments and suggestions as we plan for future educational programs. And now from NCHPEG and VHA-TV, thanks for watching.
This program is supported by an educational grant from the Robert Wood Johnson Foundation and the Josiah Macy Jr. Foundation. This program was developed and produced in collaboration with NCHPEG, the National Coalition for Health Professional Education in Genetics, RSI Focal Search, and VHA.